A very big salute to our mentors. This is Dr. Kosh, Dr. Mostaswamy and Dr. Kaushik and Dr. Ritesh and all other mentors. This is extraordinary, this is really extraordinary teachers. So I hope I have mentioned all of them. And also my study partner, Dr. Abhijit Pal. So I planned for the FRCS exam for about a year back. So we started planning with I and Dr. Abhijit Pal started planning around 1 year back. So it helped a lot. So having a study partner in your for your preparation, it helps you a lot. I think it helped me. It raised my chances of passing by 80%, more than 80. I think more than half of my preparation I got confident because we studied together. So it's very important to have a study partner. So it's important, and also because we were studying together, we could align our resources. We combined our. It's important to have organize the resources early on from this beginning and the beginning of your preparation. So it's important also to start practicing the clinics from very early on. So unless if you because in your clinics, in your exams, you might falter if you don't practice early. So uh, these are some useful YouTube links. These are important sources are from Dr. Gada, Dr. Ritesh. I think all of you know Dr. Gayatri's the clinical videos and all the important UGO links. And this is I found a very good link from the YouTube about the perimetry. You should also go with through it. The recommended books we studied Kansky and Timothy Viva and Oski. These are the books we Viva and Oski. This is very given in a Oski structured style, so it is very helpful to revise along with Kansky. Wong, this is not the book. This is a practical Viva and Oski. It's a very important book. So if you revise for 2 or 3 times, you get many questions common from the examiner. So this is a book also you should revise 2 or 3 times. And of course, you should see Dr. Gada's and Dr. Rites's video a number of times. So that helps a lot. And especially in oculoplasty, ectropy and entropion classes are excellent. And I studied the anophthalmos only from Dr. Dites's videos. And there is another video by Dr. Triple. I think you find it in YouTube only. That's also very helpful. So these anophthalmos cases are very common, and I think it will come. So if you go to Dr. Rites's video, it's more than enough. So the other important books are pivotal trials in ophthalmology. I didn't come across this trials in medical, but I'm now aware from this after Dr. Kaushik is posting in the MVUGPO group about this clinical trials in medical retina. I think these are good resources for the trials. So medicine, we studied Oxford Handbook of Clinical Medicine. This book has many good algorithms, so it's easy to revise. You should always revise with your study partner. If you don't remember, if you don't remember, it seems easy, but you don't remember unless you start discussing with your study partner. This is also these two are very concept building. So these are for concept building, and Dr. Vijay Paranswas, I hope you all have joined, are in correspondence and emails with Vijay's. Dr. Vijay will send us questions to answer. So it really helps in building up a concept and answering the questions. Uh, So on the days leading to the exam, you might feel a bit stressed because you are studying a lot, and there you are mugging a lot of things at the same time. So you get stressed. So uh, I would suggest what I experienced, that I was getting a bit stressed during the last stages of preparation. So these are two important sites. These are two. MRC of Chua site is a good revision site. If at last you can scroll through them, you can find out this is a good site for revision. So you won't feel a lot of stress revising. And Kansky, you should also, at the end of the preparation, you should go this rummage through Kansky. Important to go through Kansky. Prior to that, you should go to Timothy. Other books you should leave for before the end stage of preparation. So so instruments, the neurological pins in every exam, first is the examination, they are giving the confrontation visual fields. So you have to carry the neurological pins. These are must. And torch you will also always carry. You definitely carry. NanTD is not a must because they are all, mostly providing, but you can carry. And what I felt I was having difficulty in visualizing, you can't see that calibration. So this kind of opaque scale is quite helpful, because once you put the scale in the lid, you are seeing from a distance of 1.5 feet about, you are not able to see the measurements, calibration. So it's better to use a opaque kind of scale for the ruler for the ptosis measurements, slit measurements. So this is a link from Amazon. If this was quite helpful, because in transparent rulers you are not able to make out actually the measurements. So it will take time, but this will help you read it early, quickly. So very important topics. I got all the topics from these questions from these topics only. So these are the very important topics for Viva. So if you cover all these topics like small people management, facial nerve palsy, these are very, very important. Diabetic vitrectomy, lid tumors, like basal cell carcinoma, squamous cell carcinoma. ONTT trial is very important. So you can go through this presentation. I will post it later. So you are almost done, covered 90% of your FRCS exam, if you have covered all these topics. Now, the clinical stations, once you go into the clinical stations, this is if you get a chance, on the day of exam, if you get a chance, you get you roam about around in the OPD, in the clinic, you get a chance, you get a glance at the patients sitting outside the clinic. This sort of uh, helps you in what patients are available for the for the exams. So it sort of prepares you, helps you discuss and prepare you for the clinical stations. This is a this kind of helped me. Now, imagine a situation. I got a in the when you are starting the initial exam, you're kind of a little bit tense. So first clinical station. So was an oculoplastic station. So you kind of try to imagine the situation scenario. So there was it is a small room, around 8 by 10 feet room. So it is not so brightly lit. You have 6 to 7 people, three examiners, around 6 to 7 people in the room along with patients. So there are two examiners, one invigilator plus translator or interpreter, three patients at three corners, and plus myself. You can get a little bit tensed in such a room. So most of the examiners will not have much facial expression, and all of the patients will look glumly straight at you. So don't be, but be patient and be cool. Don't be flustered. So examiner will introduce you politely to you, and then suddenly they will start examination. Now, the first examination is the first clinical stage was a 10-year-old male child. So very high minus thick glasses. So I was you the eyes would look smaller. You can get you won't be able to gauge the size of the eyes. So I was kind of standing 2 to 3 feet away. So you have to look observe closely, and the examiner asks you, what do you see? So then he would try to give you a clue. So it's an oculoplasty station. I saw a high refract high child with a high minus glasses. So I got kind of confused. So don't get, but you should be aware of the station you are in. So this was a child who had so I was thinking, could he have a squint or not? But then suddenly I remembered it was an oculoplasty station. So then I asked him to remove his glasses. So, but I was expecting a pseudoproptosis. The very this is a high patient with child with very high minus glasses. So you kind of expect a pseudoproptosis kind of enlarged kind of globe. But strangely the eye looked smaller. Then I observed closely that the lids were drooping. Then I reached the diagnosis in case of congenital ptosis. So you need to cool yourself and start describing whatever you see. Then the patient asked me to take measurement. The examiner asked me to take measurements and we discussed about treatment options. So take home message is, don't be in a haste to take you should take a reasonable time, not with too much of time. It should take a reasonable time to detect and describe, and be aware of the clinical station you are in, because if you forget about the station, you might confuse with uh, other cases also. So you start describe in a systematic way whatever you see, then you will probably reach a diagnosis. So in oculoplasty station, you might not find a slit lamp around. So don't we are used to this kind of always used to sort of we are very feel handicapped without a slit lamp. So don't be dumbfounded. Uh, Case two, the patient was looked very much normal. Not moving. Dr. Kaushik,
Yes, yes.
the thing is not moving.
You
Okay.
can keep it now up like previous, no, not in slide share mode. Just in preview mode you can start. Yes,
Uh,
it's working.
so you will get a I couldn't make out. You can get a patient who looks very apparently very normal. So you can't make a you can kind of get clueless. So this was a lady. So imagine yourself in a situation you are seeing almost a normal patient. You're a lady looking straightly at you. So the examiner suddenly tells you examine the patient. So the situation was that I was standing 2 to 3 feet away. There was no slit lamp, no stool, no chair, no, and it was kind of not so nicely lit room. So at first it seemed very normal. I thought, what? I was confused. What should I describe? Then started describing just the I saw just a little bit of conjunctival hyperemia and the mild puffiness of lids. I thought it was little bit of age related only. Then the patient examiner said, uh, gave me a clue that suppose he complains of palpitations. So then I realized that I had uh, missed a very subtle finding of a lid retraction in one eye. So then the discussion went on to management of thyroid ophthalmopathy and all. So in our preparation, everybody, everybody suggests that you are not supposed to take history, but in certain situations you cannot. You can start with taking a little bit of history because you might be very clueless about what to look for. So if you can start with taking a little bit of history. If and you can stop if the examiner says you asks you to stop taking history and just to examine, then you start describing whatever you see. Just keep your cool and don't get puzzled. So take home message is start describing systematically whatever you see. You'll probably reach the diagnosis. In very subtle findings, the examiner might give you a clue. Case 3 was a oculoplastic case, again, post-traumatic fascicle eye, went very well. The take home message was is that if you see these two videos, these are more than enough to answer a case of anophthalmic socket. And this is a very, very common case, and you should not prepare this. So retina case was an old case, CRAO. They were asking about what kind of emboli you see. Then they went on to the investigations and management. Then whenever they ask you, see, and it was another case was a post CRVO. So they asked me to do a indirect ophthalmoscopy in the case of post CRVO. So I couldn't find much findings except that fundus was looking a little bit dull. Then I asked the patient to look sideways. So then I found the PRP marks. Then I looked closely, it was a CRVO. So it is important that whenever you give examiner, you are doing an indirect ophthalmoscope, check the peripheral retina also. Also check the other eye unless told not to. The other case was an ERM and OCT. So it was given. So that was kind of easy for me because I'm a retina guy. So the neuroophthalmic station, they will usually uh, start with a dimly lit room. They will usually so they will try. There are certain tricks they have in their sleep up in the sleep. So they will keep a dimly lit room. So if you are entering a dimly lit room in a neuroophthalmic station, you will probably you are going to get the first case as a pupillary exam. So what you have to remember that don't forget to ask this to switch on the light. So this they do a trick to keep the light dim. So you have to ask them to switch on the light to examine the people in the ambient light. Then ask the patient once you are doing the torchlight examination, you have to ask them to switch off. So don't forget ask them to keep and don't stand right in front of the patient. I found some difficulties with Dr. Gayatri Sikal's method because the patients, the examiners were kind of senior examiners. They were not acquainted with the one with the, you shine the torchlight from below, from the below to chin. The examiner kind of asked me, why are you doing like this? So you have to uh, keep your cool. Just so you have to. It's a very helpful the guy Dr. Gayatri's videos, but you can improvise and you can keep it simple. Just keep it simple. Just don't stand in front of the patient and do all the three components swiftly and confidently. You will probably find the result. So my case was this is a very important. You feel that pupillary examination is very easy, but once you start doing an RPD in a very dimly lit room, if you find you are not very sure. So you have to kind of practice a lot, quite a number of times to be quick and smooth in your examination skills. And what I felt that whenever you practice, you should have your study partner or observer looking at your clinical examination. So that helps a lot. So second case of neurophthal was an elderly irritable, quite an elderly irritable uncooperative patient. So I was asked to do a confrontation fields. So he was quite not quite cooperating, and I was, but I tried to do my test as correctly as possible, and he was changing his opinion or answers time and again. So I couldn't, but I couldn't make out what the field effect was. But I did the confrontation fields correctly with the neurological pills with the examiner observed. Was the one I had a dimness of vision, very poor vision. The examiners kept me busy with the trying, so but I did the test very correctly. So it's what I want to say that do the test correctly, that will fetch marks. And this is a you all probably all know this is a very good video link in the YouTube, which is the best video you can come across the confrontation field for visual field. You have it in the MVPUGO links. Third case in the neothal, the time was up, but later I learned that it was advanced retraction syndrome. But you should not get disheartened at this stage because you are judged by the overall performance in your station. The anterior segment is again a poor quality slit lamp was given. So be careful to check both the lids from the systematically from the lids to the cornea and the lens status. I described my findings. It was a case of Fuchs endothelial dystrophy. Then went on to management and all. So that asked about neovascular glaucoma. Then the next case was a case of neovascular glaucoma. Asked about the treatment options. And a post RK patient, another patient was a post RK patient. They asked about a cataract surgery implications. So I would like to say that prepare well, always study with a partner, discuss in groups, solve previous at least 5 years candidate papers. If you have given your best, the God will help you. God helps those who help themselves. Thank you. Okay, Dr. Kaushik.
Thank you. It was very nicely prepared. Thank you. And I think uh, like
What I want to convey is that very important to have a study partner and uh, revise at least 2 or 3 times, and you should study also do the clinics at least 4 or 5 times all the by along with a partner, so it helps to do your clinics very smoothly. Unless you do it smoothly, you tend to falter in your clinical exam, and you have a stressed kind of patients who are not really cooperating. So unless you are quite smooth and quick in your examinations, you might not be able to elicit the clinical signs. So it's important, very, very important to practice the clinics also. Okay, Dr. Kaushik, and over to you. Dr. Asma joined?
yes, yes, Dr. Asma is here. Dr. Asma, you can please start.
I'm really sorry I couldn't prepare a PPT.
No, it's okay. It's
Shall
okay.
I? Yeah. So at the outset, I would like to thank the MVPUG group because without the support and help, I think I could have cracked this exam. So I'm extremely, extremely thankful, Muthu sir and everyone here. And to the candidates who are preparing, these are my tips that Dr. Angshuman has covered almost all the important points already. So what my take will be is once you have got a slot for your exam, then and all other formalities like visa and everything has been done, then you try to find out that during the PG, whatever your notes were or which were your favorite books, you try and see that the topics from the previous candidate experiences from the past 10 to 15 years. You sort out the topics in each station. In anterior segment, what were the common scenarios, and posterior, like that. And then keep on practicing them from your notes, from your books. Books recommended are of course Fansky. And what other book I found very helpful was Will's Eye Manual. It gives you differential diagnosis and the follow-up. They were so impressed when I spoke about follow-up for every patient. I made it habit because of this book only. So just, and towards the last month, you give preference to the scenarios which were present in your center, because mostly they are getting repeated. If you are having Delhi, then preferably do the Delhi case scenarios first and then the other centers. Okay. YouTube, the list of YouTube videos that has been already shared in the group, and of course the examination techniques and everything in oculoplasty, pupil examination, all those videos are very important. So do give time and see those videos almost every day. And I actually stuck all the examination technique on my walls. There are few pages by Dr. Algonemi and Ahmed that they have sorted out the quickly how to go in the examination techniques. So I pasted them on my wall, and every day I used to practice that on my husband, my kids, because especially in pupil oculoplasty confrontation. So it became so quick for me in the exam that I didn't feel anything, before going for ptosis, proptosis, pupil confrontation. Everything was just at the tip of the top of a hat, right? So just keep on preparing and practicing on whoever you catch hold of. If you get patients, make most of them. If I get a ptosis patient, I was doing all the examinations on that particular patient. So patient also feels happy, and we also know that okay, this is the way we have to go about. Basically, it is a practical exam. They want to see how safe we are, and how no, we are not even a time consuming doctor, and within 5-6 minutes we are having all the findings on our tip. Okay, on the day of the exam, remember one thing, that nobody is fully prepared, and even the examiners are aware of it. So all that you have to do is you have to behave confidently, and you speak clearly, and don't contradict the examiner. They will interrupt you. They will ask you, are you sure about your finding? Are you really sure? Think and tell. They have these tricks, but if you are sure, you just hang on with your answer only. Don't change it. Okay, and look into the examiner's eye. And if you think that you don't know something, just say, sorry, I can't recall. So immediately they'll go ahead and ask you the next question. Keep a good number of differential diagnosis in every case. Very clear approach you should have. You should know the complications of the management that you will be talking about. And wherever multidisciplinary approach is required, you have to mention, and never forget to mention that you will follow up the patient and the frequency of follow-up. So, and even during Viva, even if we have multiple answers in our mind, speak from the commonest to the rarest causes. Okay, and when you finish it, when you meet them, you greet them, smile, and present them that you are prepared well and you are a confident candidate and not a confused learner. And so, day one, what I would say is you have to sit confidently in front of them and listen very carefully, or read the scenario that they have given you. It is very important details in their questions that are not to be missed. There are so many hints how in their question itself. So, and if you don't remember anything, just tell them, sorry, I can't recall, and follow discipline in the examination hall. They will give you very frank instructions right in the beginning. So mention all the signs that you see in one single image. Even if you see a retina image, you see just don't jump directly the finding. Just say the media is clear, disc is normal, blood vessels, and finally whatever your findings are there, you mention in that way. So they get really impressed that we are going in a systematic manner. In day two, you before in on day two, it is very important to remember that we have to use sanitizer before every patient. This they will instruct in the beginning also, but in a hurry or in the exam, one after we progress from one patient to another, we don't have a if we don't if you don't have this habit of sanitizing your hands, this can get you a negative. Okay, so and check slit lamp. before beginning in every case, because I think they deliberately they change the slit lamp eyepiece settings and everything. So use that. They even lock the slit lamp purposely, so they see that whether you know how to operate a slit lamp in day-to-day basis. And again, I said sanitizer before every patient and make the patient comfortable. I had this 30-second jargon which I told to almost every patient, that I'll be examining you. If you are uncomfortable at any moment, please let me know. So this, the translator was translating, and the examiners, they felt that this is like we should do. They already tell us in the beginning that consent have been taken. But as a doctor, I felt it is always my duty, if I am projecting a strong light into somebody's eye, if I say a few words in the beginning, even the patient feels comfortable and doesn't take much more time. I already start my examination, but I feel better to inform the patient. So keep talking as you see, and listen to examiner if they are directing you to some important findings. So one eye may have multiple findings. So keep on looking. If you find one, don't stop. You keep looking for other findings, and always try and look the other eye. If you are not told to, then don't. Otherwise, you always ask that I would like to see the other eye. Again, follow up management. You just have to be ready with the differentials, the management, and the follow for the patient, and try to be calm. It's very difficult to be calm on the exam day, and try to be really systematic. Okay, so the books that I referred were, as Kansky was my main book, Will's Eye Manual, Cakewalk, Wong, the practical one. The resources online I found iWiki, because it has got all updated and genuine information there. Dr. Gada ma'am's videos, they were really helpful for examination. Ritesh sir videos and cyber site lectures are also very important. Something that I found for important topics like multiple sclerosis, myasthenia gravis, and all most important topics were there in cyber site. So you can just go through them, and if anyone have any query, can always approach me. Towards my exam, I was not sure whether I will make it or not, but I have prepared my PPT. I will share a PDF of my experience. So in that, when I was typing my exam experience, I thought, okay, I answered at least 80% of the answers correctly. 20% were wrong or some fumbled ones, but overall, they see our overall performance. If we are best in anterior segment, but we are extremely poor in retina, then we'll definitely not make it. We have to be like good in each and every station. So prepare accordingly, and study medicine also, and try and get the best resources, like where you have clear, the answers are correct. But Walid Badr notes are also good, but there are few topics are updated now. So all the scenarios and everything. Past experience is most of the time it's the most important thing. And Cakewalk has almost 100% of the information required to crack this exam, but it's a lengthy book and difficult to revise also. So you can make notes in these two, from Kansky and Cakewalk. Write Cakewalk notes in Kansky. That will help you to revise faster and before the exam. This would be my suggestion. And anything else, if anyone have any question? Hello?
Yes, and also please examine every patient like you would do in the exam. So that is very important. Like in your clinic itself, you examine pupil, examine ptosis, examine proptosis, everything you do by yourself. So it is, you cannot act before the examiner. If you have not practiced, you will definitely do something wrong. So that is the most important thing. At least from 6 months before this, you try to examine every case, and before do not send them directly to the specialist. Examine themselves and then write down your finding and go to the specialist and ask whether you have been wrong or right. So if you continually do this, definitely you will improve.
Yeah.
You need to actually practice around at least 2 to 3 months before. Start practicing, maybe more for the clinics. That helps. At the end of the in 1 month or so, you won't be able so because you won't be getting so many cases. So would start practicing at least 3 to 4 months before. It would help.
And they some examiners are they really give us hints in every in a while, they'll stop the flow. If you are going in, they will start with a loose question, and once you are in a flow, you speak about the findings and all, they'll immediately interrupt you. Then they'll directly go to the differential, directly go to the management. So no, you be just prepared for all that, those interruptions. This exam goes so fast, you will not even realize when it gets over on the day of the exam. It is, we prepare so hard for so long, and hardly, and immediately after the listening to the question, the most important thing we will forget, and towards the end of that viva we remember, okay, this was the answer, but I didn't say anything. So that happens, but we have to hold our horns, and we before going to the next station, we forget about the current station if something goes wrong at that particular station. Like for me in the Brown syndrome, he asked me everything I could answer, then towards the head position, head posture, I said chin up. Then he's like, are you sure? Are you really sure? Think this is your exam going on. These are the examiner's words. He told me, is this is your exam? Huh? Think and tell me. Are you sure it is the head posture? Are you sure? Then I was like totally clouded. I didn't say anything and the bell rang. And then I got to the next station. Then I was like, okay, forget it. Now next station is new station for me. Then it was subhyalite hemorrhage, neovascular glaucoma, pseudo exfoliation. So most of it I could answer. There will be few things that you will not know in every scenario, and don't get bogged down. We are not books, we are humans. So even they are aware of it. So don't get carried away at any station. Just be confident and be relaxed before you proceed to the next one.
And I think we should start with the most basic differential, then go on to that last differential. Start with the basic answers, then proceed. Otherwise, suppose if you are discussing about basal cell carcinoma, we will start with vismodegib. So they will be disappointed. So management should start with frozen section biopsy and all. You don't say atypical answers at the start. Should say the common answers initially, then go on to the, if they keep on asking you, then go on to the atypical answer points. That's important. That might disappoint them.
I have a query. While examining the posterior segment, we should see the posterior part first and then go to the periphery, or vice versa?
They usually they will ask you, once you are seeing doing the indirect ophthalmology, you will please see the posterior part only. Then you should check all the quadrants. You should see the entire retina before you come to a diagnosis. Say your diagnosis. You should see all the quadrants, because it's not that you see only the posterior segment. You have to see all the when you are using indirect. During 90 days after, you cannot see the periphery. If you are up to whatever extent you can see. But indirect, you have to see all of the periphery as much as.
I'm asking whether to do the posterior pole first and then the periphery, or first periphery and then the posterior pole.
Posterior pole, then the periphery.
First, no?
Yeah.
Oh, thank you.
And for indirect for fundus examination, practice to use the medium to light illumination. Don't do directly for brightest illumination. Even with slit lamp, all they appreciate when the patients are comfortable with us. If we are showing bright light, the patients are also, they teach the patients also to, the patients sometimes they act, they will say, oh, this light is too much, all that. So you try and practice with dim illumination or medium illumination. Even with IO, it is possible. For my case, it was a very old patient. I started with the retina periphery, then I spoke about the media, then I spoke about the disc and the macula. So they were okay with how I proceeded, because the patients are sensitive to bright light. If we directly go to the posterior pole, some may not like it. So I went to the periphery. I asked the patient to look down from inferior, and then all the periphery I saw it. I kept on speaking about the PRP scars and this, that, and then I spoke about
Yes.
the posterior pole.
Yes, it is better to examine the periphery first, then go to the posterior pole, because the examiner might look at it also, like what you are doing. People who are like more if pupils are not dilated enough, then once you look at the posterior pole, the pupil will constrict more, and examining the periphery will be more difficult. And also, patients might be more photophobic if you examine the posterior pole. So sometimes examiner may tell like examine the posterior pole, then you can directly see with see the posterior pole. But if the examiner says that do indirect ophthalmoscopy in this patient, then do as per protocol. Protocol is you examine periphery first, and then you examine posterior pole.
Yeah, and one more trick, in this exam, I felt, and even with the Amman candidates also, they also experience the same thing. They'll keep all the lenses in front of you. They will tell you the patient, I see the macula of this patient. So you have all the lenses 20, 30, 78, and 90. So they will stand and see that which lens you will pick up. You will see the fundus with 90 also, with whatever thing you want. But if you have a slit lamp, you have a IO, you have all these lenses, then what will you choose in your scenario? So
Yes.
I went ahead with, so I went at a slit lamp and with the 78D to see the macula. Then for a for a BRAO case, I took the 90D. The examiner said, you see this patient with 90D, like that. So you remember that what is the examiner's expectation from you. They will give you very clear instructions. So you hear it. Every word from their mouth is your exam. You have to listen to them, otherwise we cannot make it, because they are there to help us. They help us in a very different way we are not accustomed to, but be ready for everything on the day of exam.
What about scleral depression? If they are
No, that all they don't expect.
Actually, you will be having a patient sitting, who is sitting. You have to do a index for a sitting patient, not a live.
okay.
And scleral depression will not be like, it is 99.99% that scleral depression will not be asked,
Okay.
because it's a little like maybe painful. And this scleral depression can be there in if you are in a retina subspecialty exam. But in FRCS, I don't think anybody has been asked to do scleral depression as of now. No previous experience has this.
Okay.
Yeah. See, even if when you think that you are wrong, other candidates and all, if we ask, the same the case in oculoplasty which Dr. Angshuman was talking about, that child, he was some 7-8 years old, and he was rotating on the chair, and I just felt, how will I examine that child? His mother was there. She removed the glass. I said, sir, the child is wearing high power minus glasses. Then he said, how will you examine? What will you do? I said, I want to see do the ptosis. I think this is a pseudotosis. Then he said, why you are saying pseudotosis? So I said, sir, the eyeballs look really, the sulci are both very deep in both the eyes, and the lid crease is absent. So he was like, lid crease, how will you see? In which gaze? I said, lid crease is seen in down gaze. Then he's like, are you sure? Are you sure about this? I said, yes, sir, lid crease is seen in down gaze, and we also measure it in down gaze. Then he's like, why do you think it is pseudotosis? I said, sir, I think the eyeballs are really small for this. He said, no, his eyeballs are normal for his age. I said, sir, if the eyeballs are normal for his age, then it is a congenital ptosis. And when I tried to take the measurements, I saw the left eye was actually a microphthalmic eye with a coloboma of the iris, microcornea and everything, right? Severe ptosis, MRD was in minus in the left eye. The child was using only the right eye. Right eye was having a -1 MRD. Yeah. So I was almost sure that, okay, this is like a pseudotosis, but just to confuse, it was kept like that. But then I changed when he said that the eyeball is normal for his size, for his age, I said, sir, it is a it's a congenital ptosis. Then he asked me, why you want to keep your thumb on the eyebrow? I said, to negate the frontalis action. One tricky question he asked me is, what are the material that you will use for a frontalis sling? So I said all the things which I could recall, like our silicon bands and ethibond, proline. And he's like, proline, what is ethibond? What is proline? Will you use proline or polypropylene? So they both are same. And I was like, sir, proline. Then he was like, then I said tensor fascia lata, and then the next examiner came and the same thyroid eye disease. So I diagnosed the case as proptosis. Then he asked me the differential diagnosis. So I said, sir, for a unilateral ptosis or a bilateral, the first differential is the thyroid eye disease, then cavernous hemangioma for a young lady, or tumor, any inflammation tumor be in the orbit. Then he said his mother told you that this eye has been big since her childhood. So I said, sir, it could be a ophthalmos, congenital glaucoma leading to a ophthalmos. It could be a micro-ophthalmos in the other eye, or it could be a shallow orbit. Then, so, for everything, you just have few DDs, so that, they will go to the next question when they get their word from your mouth. So you keep on talking once they ask you. Don't stop. If there is a pause, that means you are wasting your time and the examiner's time. Just keep talking. And relevant talk. Okay. Okay.
Are there any other queries? Thank Dr. Angshuman and Dr. Asma. I think these are very important topics, and like you actually we learn from other people's experience only. So
Okay, thank you, Dr.
Yeah.
Kaushik.
thank you. I think we can conclude. Thank you.
Thank you, Dr. Kaushik. All the best to everyone.
All the best.
Good day. Good day.
Thank
Yeah.
you.